Hello friends, welcome to Shrinetralaya. In this case, we will be operating a very high myope case and we will implant a single-handed CTR in the bag for stabilization of IOL, and we will demonstrate implantation of a 3-piece IOL. Additionally, we will see intraoperative fundus examination in high myope cases. So, main port and side port is performed. Viscoelastic is injected into the anterior chamber. Rhexis marker is used to have good centration of rhexis. This also helps to control the size of rhexis, and 5.5 mm rhexis is already performed. Hydro is very important in high myopes as it must separate all the fibers from the capsule, because otherwise it will remain stuck and it will be difficult to remove, and you have to go really deep into the like a midvitreous to remove these cortical material fibers from the posterior capsule. So I have decided to rotate this nucleus very nicely so that all cortical materials are well separated. So you can see a very nice rotation of the nucleus will clean the cortical material, and all the fibers will be free from posterior capsule. Here phacoemulsification started. To perform a phaco in high myope, we have to go really deep, and you should have a good hold of the nucleus. You should be able to crack this nucleus well. It is better idea to pull the nucleus to the pupillary axis and then perform phacoemulsification procedure. It is good idea to take out cortical material first so that nucleus is well free from the bag. You can take this free floating nucleus to the pupillary level and perform the phacoemulsification. Fluctuations in chamber is very common in cases of high myope because of high elasticity of sclera. You can note the fluctuations in the size of pupil while performing phaco, which indicates that the elasticity of this eyeball is slightly on higher side. Few cortical material fibers are taken out with the help of phaco probe itself. Anterior chamber again is filled up with visco. You can note the whitish reflex from the retina, which is indicative that there is definitely not a very healthy retina behind. A visco is injected. Cortical material fibers are taken out with a coaxial irrigation aspiration. Be careful while performing this. Once this is performed, I am using a 27 gauge cannula with 2 ml syringe saline to push into the anterior chamber so that chamber remains formed, and that way we prevent the posterior detachment which can occur during this procedure. I have injected a single air bubble in the anterior chamber, and as soon as I have done that, you can very well see the Foster Fuchs spots, atrophic retina, optic disc, which is very clearly and nicely seen. The intraoperative observation of these things will indicate that the post-operative vision is going to be less, and you can take the consent accordingly. This was not a case here because even before surgery also it was visible, but if you have a very thick PSC or a mature cataract, this step will help you a lot. But it is interesting to watch this retina under the microscope. Visco is injected into the anterior chamber again to form the anterior chamber, and these type of cases the bag is not very healthy. Even though they look now okay, the subluxation is not uncommon. The contracture is something which can happen any day, or the IOL can go for decentration even later day. This is a do it yourself like single-handed CTR injector system which I have prepared from 1 ml syringe and a IV cannula. The video for same is already available on my YouTube channel. I am taking a CTR and loading this CTR into the CTR injector system. The advantage of this system is that you have to you can inject the CTR with a single hand, and you can go really deep near the bag in the corners where you will inject it very slowly and comfortably without causing any stress on the zonules. And in a deeper set eyes or in high myope cases where you find it difficult to enter to the level of bag with the help of forceps, it is very easy to implant this particular CTR ring with this particular instrument, which is very useful and can be prepared very easily. Now I am injecting a CTR slowly, and I am following the curvature of the bag. And lastly, I will go into the periphery and inject it so that the trailing haptic will not cause much strain on the zonules or will not be like too much of pressure on the zonules while injecting it. Once that is done, here I am implanting a 3-piece IOL. The 3-piece IOL has advantage as they remain very stable, and I am implanting a Alcon 3-piece IOL with a type B cartridge, which is a very useful cartridge, and to implant this, it is a very nice technique. So the first haptic should not be bent and you should keep it straight. The second trailing haptic should be attached to the hook which is there on the cartridge itself. You can see the trailing haptic has gone to the side and it will not come in between while injecting the plunger in forward. This shape has to be followed. While injecting this IOL, the leading haptic do not go very properly. To make it in a proper direction, we can pronate our hand and make it in a proper direction. But rather than pronating my hand, which requires a slightly larger size incision, I would like to use my left hand dialer to give a proper direction to the leading haptic, thereby directing it properly into the bag as shown in the video. The second trailing haptic can be left behind and which can be dialed with the IOL dialer. You can note how easily it has got implanted into the bag without any strain. The visco is washed off and thereby we complete the case. I hope you enjoyed this case. Do subscribe to our YouTube channel Dr. Pankaj Lande for more such videos. Additionally, there is a WhatsApp channel with the name Dr. Pankaj Lande Surgical Videos. You can subscribe that too. Thank you and good day.